for inviting me to speak about cervical cancer prevention. We need to increase awareness of cervical cancer as it is nearly 100% preventable. My name is Linda Ahn. I'm an employee of Roche Diagnostics Corporation, functioning as an OBGYN consultant within the non-commercial division of Medical and Scientific Affairs. The data presented is intended for educational use to provide the participant with scientific evidence-based information in compliance with FDA guidelines. All trademarks, trade names, images, or logos mentioned or used herein are the property of their respective owners and are not used for the purpose of promotion or as an indication of affiliation with the provider of any particular good or service. This program was made possible by an independent educational grant from Roche Diagnostics. So for the presentation today, we're going to start with an introduction to cervical cancer, and then talk about HPV facts, then talk about how we're going to prevent cervical cancer. Cervical cancer is cancer of the cervix, which is the lower part of the uterus that connects to the vagina. Cervical cancer occurs when the cells in the cervix grow out of control, and over 99% of cervical cancers are caused by the HPV virus. And women of all ages with the cervix are at risk. As far as the statistics around cervical cancer, again, greater than 99% of cervical cancers are caused by the HPV virus. 4 out of 5 women will be exposed to this virus by age 50. The surprising thing about cervical cancer is that it is nearly 100% preventable with proper vaccination, screening, and treatment. So we need to increase awareness to help prevent it. Cervical cancer is the 4th most common cancer in women around the world. And women in areas with no access to screening are, of course, impacted the most. Globally, the World Health Organization estimates that there were 570 new cases of cervical cancer in 2018, with approximately 311 deaths. Unfortunately, women in the US are impacted as well. Lack of access to screening or missed cervical screening opportunities are the reason. According to the American Cancer Society, approximately 13,800 new cases of invasive cancer will be diagnosed in the US in 2020, and about 4,290 deaths. In the US from 2007 to 2012, there were 8 million women aged 21 to 65 that reported they had not been screened for cervical cancer. 7 out of 10 women who hadn't been screened in that time frame had a regular practitioner and health insurance. Approximately 50% of new cancers were in women who had never been screened or hadn't been screened in that time frame. This graph shows the incidence of cervical cancer in the US from 2000 to 2017, separated by race and ethnicity. The red line shows the incidence for all races. More African American women and Hispanic women get cervical cancer than women of other races and ethnicities. One reason is decreased access to screening and follow-up treatment if needed. This has to change because cervical cancer is a preventable disease. Currently, there are investigations into self-sampling to help women whose challenges prevent them from routine screening. The unfortunate fact is that African American women have the highest mortality of all racial and ethnic groups for cervical cancer. Cervical cancer is preventable. We need to remedy this by increasing HPV vaccination, access to screening, and follow-up treatment. So we're going to talk about HPV facts. What is HPV? HPV is the human papillomavirus, and it's spread through skin-to-skin contact as with sexual activity, and any sexually active person is at risk. Usually, there are no symptoms, but if it does not go away on its own, HPV can lead to cervical cell abnormalities and cervical cancer. So the risk factors for cervical cancer are persistent HPV infections, and factors that increase the risk are rarely or never being screened, history of sexually transmitted infections, HIV and other immunocompromised conditions, and smoking. So smokers with HPV are 2 to 3 times more likely to develop cancer. So HPV is the most common sexually transmitted infection. It is the known cause, again, of greater than 99% of cervical cancers. There are over 100 types of HPV, of which at least 14 types are the cancer-causing or the high-risk types. The high-risk types are linked to cervical cancer, whereas the low-risk types are linked to genital warts. The HPV 16 and 18 account for 70% of cervical cancers. Most women will be exposed to HPV at some point, so having HPV is not a sign of infidelity or promiscuity. There is no way of knowing how long the HPV infection has been present. Most women will clear an HPV infection within 2 years, and most women with HPV do not get cervical cancer. However, persistent HPV infections can cause cervical cancer. As far as symptoms, generally early on, there are usually no symptoms, but as the disease gets more advanced, you may have symptoms such as vaginal bleeding, especially postcoital, meaning after intercourse, unusual vaginal discharge, or even pelvic pain. As far as treatment, there is no treatment for the virus itself, but there is treatment for the health problems that the virus causes, such as genital warts and cervical precancer. Now, we talked about cervical cancer being associated with HPV disease, but other cancers include anal cancer, vulvar and vaginal cancer, penile cancer, and cancers of the oral pharynx, which is back of the throat. So HPV is transmitted by skin-to-skin contact in the genital region, whether it's vaginal, oral, or anal sex, or even non-penetrative activities where the genitals are in contact, although this is less frequent. So essentially, HPV is transmitted between partners. And condoms are recommended, but I just want to make sure that we understand that it is not 100% guarantee of protection, because it may not protect all areas of contact in the skin and the genital area. And I get this question a lot, and about whether there is an HPV test in men, and unfortunately there is no HPV test for men at this time. So we're going to move on to how we go about preventing cervical cancer, and it's through a combination of 3 different methods. First, HPV vaccination, then cervical cancer screening, and cervical cancer treatment. So as far as the HPV vaccine, since HPV vaccine was first introduced in 2006, there's been a significant reduction in HPV infections. In the US, the HPV vaccine covers 9 types of HPV strains, including HPV 16 and 18, which we know causes most of the cervical cancers. HPV vaccine has a potential to protect greater than 90% of HPV attributable cancers. And after more than 12 years of data, and greater than 120 million doses of HPV vaccine distributed, it shows that HPV vaccine is safe and offers long-lasting protection against HPV infection and disease. So as far as the safety, the vaccine went through rigorous testing, and side effects with this vaccine are generally mild and tend to go away on their own, and include things such as redness or swelling around the injection site, maybe some muscular pain, fever, and headaches. And again, they tend to be mild and go away on their own. The CDC and the FDA continuously monitors for vaccine-related adverse effects. So the vaccine is recommended for boys and girls around age 11 to 12. But the whole goal is that you want to vaccinate before the kids become sexually active, so it can be started even earlier at age 9. It's also recommended for teenagers and young adults who haven't been previously vaccinated through age 26. What is new is that recently the FDA expanded the vaccine to age 45 for adults who had not been previously exposed to HPV. They need to discuss this with their providers to figure out if this would be a benefit in their case. As far as the vaccine dosing, for children starting the vaccine before their 15th birthday, it requires 2 doses. So if one is given today, the second one needs to be given about 6 to 12 months from today. And for teenagers and young adults starting the series after 15, it requires 3 doses. So if one's given today, the second one would be 2 months, and then the last one 6 months from today. Now, moving on to the second method, which is cervical screening. It is done with Pap test and HPV. So the Pap test looks for the changes on the cells of the cervix, whereas the HPV test looks for the virus that causes these changes. And how this testing is done is during a pelvic exam, a speculum is placed in the vaginal area and widened so that you can visualize the cervix, which is what you see on the right side of the screen. And a cervical broom or a spatula is used to collect the specimen. And this cell sample is put into a liquid vial and sent to the lab. And I do want to mention that Pap and HPV test can be done from the same sample. As far as the screening, there are many professional societies that put out recommendations, and they have been changing every few years because of the rapid knowledge being gained around cervical cancer. But I do want to mention that screening is vital to cervical cancer prevention because most precancers are asymptomatic, and the goal of screening is to identify precancerous lesions that can be treated to prevent it from going to invasive cervical cancer. This chart shows the 2018 United States Preventive Service Task Force Cervical Cancer Screening Recommendation, which is often referred to. As you can see, there are 3 different methods of screening: Pap Cytology, Pap HPV co-testing, and primary HPV screening, which is just the HPV test. So the Pap Cytology test is the oldest method, and it's recommended every 3 years for women aged 21 to 65. But it is declining in use because of the fact that it has low sensitivity due to the subjective nature of this test. But because of the increasing knowledge that we have about HPV and its cause for cervical cancer, it has become adapted into the guidelines, first in Pap HPV co-testing, then later in the primary HPV screening. In these scenarios, it's tested every 5 years, starting at age 30 to 65. Now, what is new is that just this year, American Cancer Society put out new guidelines recommending primary HPV screening over the other methods. And they recommend testing starting at age 25, going every 5 years until age 65. And this is now considered the preferred method over Pap HPV co-testing and Pap cytology alone. Now, when we talk about screening, we're talking about screening that applies to women at average risk and don't apply to individuals who are at increased risk for cervical cancer. And so those women with high risk may need to be screened more often and include women who are persistently positive for HPV infection, who have a history of high-grade cervical disease and cancer, who may be immunocompromised, including women with HIV infection, and women who've had in utero exposure to DES, which is a drug that was used in the past to prevent miscarriage and has been linked to increased cervical cancer. As far as the screening results, if you have positive HPV, just remember that most HPV will clear on their own and not cause cervical cancer. If you have an abnormal Pap, it means that you have cell changes on your cervix, but it does not mean that you have cervical cancer. And so you need to make sure you follow up with your healthcare provider to do follow-up tests or monitoring. And follow-up tests can include colposcopy, which is what you see in the lower right-hand corner. You see a clinician looking under the microscope at the cervix, and that's what you see on the monitor on the computer screen. And biopsies may be obtained in areas that look abnormal to be sent for diagnosis. Going to treatment for cervical and precancer and cancer. So this is the treatment of precancer or early cancer. And essentially the procedure is a conization procedure where a cone-shaped piece of tissue is removed from the opening of the cervical area, which is the transformation zone where most early cancers start. And you could see that example right here on the right lower hand, where a cone-shaped piece of tissue is removed. And this may be enough to cure early precancer or can be used to diagnose the extent of disease. And this shows why it is so important to follow up on results and get treatment, because finding disease early and treating it at an early precancer stage can prevent it from going to invasive cancer. Now, for treatment for more advanced cervical cancer, it may require surgery or even chemotherapy or radiation, but I'm not going to go into that in much detail today because fortunately we don't see this that often. The World Health Organization called for a world free of cervical cancer, and their proposed 2030 target is that 90% of girls get vaccinated with HPV vaccine by age 15, that 70% of women get HPV screened at age 35 and 45 and get managed appropriately, and that 90% of women identified with cervical disease receive treatment for precancerous lesions or invasive cancer. Since the introduction of Pap cytology, it's had a profound impact on cervical cancer incidence in the US, but the effectiveness of cytology has largely leveled off in the last several years. And we need to do better because women in the US are still dying of a largely preventable cancer. So what is the future of cervical cancer screening? When we think about the continuum of cervical cancer screening, we have to think about 3 different buckets. We start with the screening step, where we accurately identify women at risk. And for women who are identified at risk, we need the triage step to figure out who is likely to have disease and need to be effectively referred to colposcopy. And for women who have colposcopy and had a biopsy, we need to diagnose to identify precancerous cervical lesions. At Roche, we are committed in our efforts to eliminate cervical cancer by moving beyond status quo and investing in new technologies to improve the current state of affairs in cervical screening and diagnosis. So to start with the screening step, we start with the HPV virus testing, which identifies women at risk for developing cervical cancer. This shows the results of a large cervical cancer screening study called Athena, where they compared the ability of Pap versus HPV DNA to detect high-grade cervical dysplasia. And what it showed is that Pap Cytology was able to pick up 53% of high-grade dysplasia, whereas the HPV DNA picked up 92%, which is a 72% increase in sensitivity for the HPV test. Other studies that compared Pap and HPV also find comparable findings. So this is the reason why more and more we are leaning toward HPV testing as far as cervical cancer screening. This chart shows the FDA-approved HPV test in the US. And what I want to point out is that not all FDA-approved tests are equal, and that some HPV tests genotype, meaning identify the high-risk HPV types such as 16 and 18 that we discussed earlier, whereas others do not. Also, some are approved for primary screening, which required more rigorous testing for clinical validation, whereas others are not. Now, just to review, we know that HPV is the cause of cervical cancer in greater than 99% of the time. But fortunately, most of these resolve on their own. So having a positive HPV test does not mean that a woman is at risk for cervical cancer. And this is where the triage step comes to play. We need to help determine which HPV positive women are at the greatest risk for disease and would benefit most from colposcopy. Roche offers the dual stain biomarker test, which identifies HPV infections causing cellular transformation. And this is shown in the center slide of the dual stain biomarker. And just to break this down, one of the biomarkers is P16, and it is a protein that's involved in cell cycle arrest. The other biomarker is Ki67, which is present during cell cycle division or proliferation. These are mutually exclusive proteins and should not be present together, because when they are, it's like having a red light and a green light at the same time. You know something is wrong. And an example of a positive result is shown in the center slide, where you see the P16 and the brown cytoplasmic stain, and the Ki67, the red nuclear stain in one cell. When you see this, this indicates cell cycle deregulation and is a hallmark of a transforming HPV infection. And it's a valuable tool to identify the presence of cervical dysplastic lesions and to identify women that need to go for colposcopy. Another method of triage that has been discussed is extended genotyping. So on top of identifying HPV 16 and 18, which we know are the highest risk for cervical cancer, doing further identifying of other types that may also place a woman at risk. And while this identifies women at risk, it does not tell you who has the transforming HPV infection today, and you don't know where they are in their disease. So when you send a woman away to return for testing anywhere from 1 to 3 years, you don't know that they might not already have a disease. And when you use expected management like this, there's always a risk for loss to follow-up. Now that we've taken a woman to colposcopy and perhaps had a biopsy, we need to diagnose. So we need to identify which women have the precancerous cervical lesions. And that's where the use of P16 immunohistochemical stain is helpful in being used with the H&E stain. It provides objective information for diagnostic decisions and can aid in the diagnosis of cervical dysplasia. As far as the left side, you see the H&E standard stain. And then on the right side, you see that same tissue with the P16 immunohistochemical stain. And what you see is that the brown staining highlights the cervical dysplastic areas, which helps pathologists diagnose the cervical biopsy with higher sensitivity and specificity versus just using the H&E stain alone. So it substantially reduces the number of false negative high-grade results. So the Roche Diagnostic Cervical Cancer Portfolio of Advanced Tests supports labs and clinicians in their efforts to provide optimal screening and testing to protect women from cervical cancer. We screen with HPV to identify women at risk. For those women who are identified at risk, we triage with the P16Ki67 dual stain biomarker to identify women who have transforming HPV infections to effectively refer them to colposcopy. Then for women who have a colposcopy and have a cervical biopsy, we diagnose with P16 immunohistochemical stain to identify precancerous cervical lesions. So in conclusion, cervical cancer can be prevented with vaccination, screening, and treatment. So we vaccinate boys and girls starting at age 11 and 12. We screen with HPV or Pap or a combination of both. And we follow up abnormal tests and treat. So the final message is get vaccinated, screened, and follow up on your results. It can save your life. Thank you.
And we want to thank Dr. Linda Ahn for her presentation. At this time, if you have questions that you would like to ask Dr. Ahn, please post those in the Q&A box. Good afternoon, Dr. Ahn. First question that we have for you for this Q&A portion of our session: why don't we test HPV in women under 30?
Hi, everybody. Thank you so much for attending this conference and listening to my presentation. So the answer to that is, as we discussed, HPV tends to clear on its own, and it actually does a better job of this in younger women than even in the older ones. So we try not to test too early because it generally leads to a lot of additional testing like colposcopy. And sometimes, if you just let some time pass, these are infections that might have resolved on their own. When you do procedures like colposcopy, it can have negative impacts on especially younger women who kind of take away from that they might want to avoid gynecologists, or they might want to avoid new partners because then they feel kind of nervous that this might, further, sexual intercourse might lead to these type of tests going forward.
Do we have to request HPV, or is it automatically done when a Pap test is done?
So, this depends on the physicians that you're seeing. And the standard of care right now is to do HPV testing on women over 30. As we discussed, we don't want to do it too early. So you may want to make sure that you check with your physician, because, there are 3 different methods as we talked about. You can do Pap alone. You could do both Pap and HPV testing and the HPV test. So you may want to ask your physician, but because of the knowledge around HPV, it is very important that that's part of your testing, especially if you're over 30.
What new methods are being researched or developed to help improve cervical cancer prevention?
So as I alluded to earlier, one of the new methods that's being looked at is self-sampling. And what that means is, you send a kit to, say, a patient's home, and they might do their own sample and send it into the lab. And the reason why this may, be a real advantage is that some women have trouble getting into routine exams. Some women kind of feel anxiety or, feel that it's inconvenient. So if you make it convenient and maybe less embarrassing for some women, this may increase testing, and it might have potential to save lots of lives going forward.
Is uterine and cervical cancer similar?
So they are not, they are kind of continuous with each other because the cervix is the lower part of the uterus, but they are actually different in that cervical cancer, as we discussed, is mainly caused by HPV virus, whereas uterine cancer have other causes, like, for instance, extra hormones being produced. Sometimes you have genetic predisposition to it, so it's caused by a different mechanism.
What do you feel the faith community can do to address cervical cancer?
I think because this is such a preventable disease, I feel like the more we talk about it, the more we're going to be able to kind of help women prevent it. Because the good thing about cervical cancer is we know what causes cervical cancer, and there are so many ways to prevent it. First, with the vaccination of younger children, with the screening, because most cervical cancers are in women who have never been screened or hadn't been screened in the time frame that was recommended. So I think just increasing that awareness is going to help. The other thing is that when you pick up early disease, like precancerous situations, minor procedures like that, the conization type procedure can really kind of nip it in the bud so it doesn't have to go any further. And a lot of these procedures are, fairly simple in that they can be done in a doctor's office. So you want to make sure you catch it early so that it could prevent it from going further into a more advanced scenario.
Why do women 65 or older no longer need to be tested for cervical cancer?
So, and that's for the general population. As we discussed, these screening recommendations don't apply to everyone. In order for you to stop screening at 65, you do have to have 2 normal tests within the 10 years prior to you stopping. So if you're 65 or even older and you don't have those tests, then it's a test that actually may need to be continued further. So it applies to women who've had routine testing and have verified tests that were negative.
Another presenter stated started HPV vaccinations at 9. Why the difference?
So it really isn't the difference. I think the standard recommendation is around 11. The whole point is that you want to vaccinate children before they become sexually active. So in cases where you think that, a child might become sexually active earlier, I did allude to this, you do want to vaccinate even earlier than 11. So 11 is just kind of the standard recommendation. It doesn't mean that it applies to everybody. One thing that I also want to add is that a question that I get asked often is if a woman already has HPV infection, should they be vaccinated? And the answer to that is, especially if they're in the age range, which is generally 26 and under, even if they know they have an HPV infection, yes, it is still recommended because Gardasil 9, which covers 9 different strains of HPV, so covers 9 different strains of HPV, and it's kind of rare that one individual would have been exposed to all 9. So even if they've been exposed to 1 or 2 strains of the virus, it's possible that you could protect against the other strains, for instance, like the ones that could potentially cause genital warts.
What does it mean for those who test positive for HPV and it doesn't go away on its own within 2 years? What are the health risks that come with being positive for 5 years or more?
So, as far as the risks are in those cancers that we talked about. So in particular, having a persistent infection increases your risk of cervical cancer. It still doesn't mean you're going to have cervical cancer, but the fact that it's sticking around means that you are at increased risk. And of course, the other cancers that we talked about, like anal cancer, vulvar, penile cancers, but it doesn't mean you have cancer. It just means you're at increased risk because your immunity is not able to clear the virus, in a timely manner. So you should definitely be monitored closely so that those risks either go away or there's some kind of a treatment that's performed for it.
When you have a family history of reproductive cancer, when should you have your first Pap test?
So one thing that I think a lot of people are not aware of is HPV is not a hereditary situation. So HPV is a sexually transmitted virus. So even if a family member had cervical cancer, this cancer is not increased because of that situation. So unlike other cancers such as breast, uterine cancer, ovarian cancer, cervical cancer is actually not hereditary. So a relative having this cancer does not increase your risk. So that also means that does not mean that you should get tested earlier. In fact, we lately have been kind of pushing back the screening test because of the fact that a lot of these HPV infections, especially in younger women, are cleared. So given time, a lot of them will resolve on their own.
Can you speak to HPV screening home test?
So, this is still investigational. When we talk about self-sampling, it's mainly talking about the HPV testing. It's being looked at, but there's no test that is actually out there right now. But, we do feel that this is something that is definitely worth investigating, because I think it would eliminate a lot of women who have some hesitation in going into the doctor's office. So any type of screening is obviously an improvement over no screening.
Should you have the HPV test for those who have had hysterectomies?
So the recommendation is that if you had negative tests prior to the hysterectomy and that hysterectomy was not done because of an HPV or a cervical cancer situation, you do not need to do further testing. The confusion sometimes comes in when I have patients coming in saying, I don't think I need cervical screening or HPV testing anymore, but that doesn't apply to women who had it for cervical dysplasia or cervical cancer. So you kind of need to know why you got that hysterectomy, as far as do we need to do further testing going forward.
HPV vaccines for young people are not well received in the African American community, especially faith community, as it is sometimes perceived as encouraging sexual experimentation, but primarily vaccines are not well trusted universally. How do we reassure parents that this vaccine is safe and needed?
As a gynecologist, I get that question a lot about parents being nervous that giving the vaccine is a permission for, children to have sexual intercourse. And I find that that is not the case. If that is their, interest or intent, whether you give them the vaccine or not, they will go forward and participate. So I think you want to protect them because, as we discussed, it is very prevalent out there, and you want to make sure you protect them against cervical cancer. As far as the safety, as we discussed, this has been out there since 2006, and we don't know of any huge adverse effects. It's generally those ones that you normally get with vaccines, which is mainly things around, like a little tenderness at the site, maybe some redness, some muscular pain. So minor ones that tend to go away on their own. The benefit that you get is so much greater than the minor side effects that I feel like, yeah, you really definitely want to protect your child, because, this vaccine has a potential to prevent cervical cancer.
Is the HPV vaccine a part of the routine childhood vaccinations?
I'm not a pediatrician, so I don't know that for a fact, but it's definitely recommended, and your pediatrician should be recommending this at age 11 or even earlier, as we discussed. It's unfortunate, but yeah, I do know that some parents choose not to give it to their children, which is unfortunate since this disease is so preventable.
For those of us around the age of 50, this wasn't talked about. Since it is a sexually transmitted disease, how are we treated?
So, if you may already have had the exposure, because sometimes you get exposed even years and years ago, and your body can kind of, have it in a dormant state. So the way to really fight this is getting screened, because the good thing about the situation is that cervical cancer, fortunately, is a very slow progressing disease. So as long as you pick it up early, you may be able to prevent it through a minor surgery like the LEEP or the conization procedure. So it is very preventable just by screening. You can pick it up before it gets to any advanced state.
Do you have to request HPV, or is it automatically done when a Pap test is done?
So the standard again, is usually to do the HPV test starting at age 30. But, this depends on the clinician, because there are still clinicians just doing the Pap smear. So it is a question that you want to ask your gynecologist or your family practice doctor who's doing the screening, because there are, again, many different ways to do the screen. And, I would say it is very important to get that HPV in there, because we know that it's much more sensitive at picking up disease than just the Pap smear. And that's why more and more screening methods are going toward including that HPV in the testing. So it's not automatic, but you should have this discussion with your physician, and it is recommended for women over 30.
What is the best way to request it? I have been told to ask for a C125, and I'm not sure what that means.
Yeah, so the CA125 is actually a different test. That is a blood test that's sometimes done for ovarian cancer screening, but it's not recommended for routine screening. It's generally because that level can be high, whether you have, say, cervical ovarian cancer, or even other GI upset, or just inflammation of some kind. So that's not a cervical cancer screening test. That's actually something that's followed for women with ovarian cancer. So it's not recommended as a screening. It's a test that is done for women with established ovarian cancer to see if they have a recurrence. So that's not a cervical cancer screen.
From your experience, has the vaccine caused any issues for a teenage girl?
And I'm assuming that is talking about side effects.
Yes.
Yeah, so nothing out of the ordinary, just what we discussed, just minor aches and pains or just discomfort that tends to go away on their own. So unless you're someone who had really bad reactions to previous vaccination, this should not prevent anyone from getting the vaccine.
If you had cryosurgery for an abdominal Pap, should you continue screening after age 65?
So the new recommendation is that if you've had cervical abnormalities, that you actually need to be followed for 25 years after that procedure. And this is a slight increase from before, because it used to be around 20 years. So yeah, I think what I want everyone to take away is that all of those recommendations that we talked about with the screening 3 to 5 years apart, those apply to women who have had normal or routine risks, not for women who've had procedures done before or are considered at higher risk.
I confuse this test with a cervical cancer screening because of family history.
I'm not quite sure. So I think we're talking about whether cervical cancer has anything to do with family history. And I touched on this a little bit earlier, and it's actually one of those rare cancers that really have no relation to family history, because it's caused by a virus. So unlike other cancers that increases your risk if somebody in your family has that cancer, this one is actually caused by the virus. So someone in the family having had cervical cancer does not increase your risk of cervical cancer.
Are there any research undergoing about a cure?
I am not aware of a research for the cure at this time. I could be wrong, but I'm not aware of this at this time.
And one final question, how are we allies for the fears of parents who don't want to get their children vaccinated against a disease they may not get?
I think it's through education. We have to make everyone aware that this virus is very common. As we discussed, they estimate that 80% of women are exposed to this by age 50. So obviously, yes, most people don't get cervical cancer, but the fact is they have a lot of chances of exposure, and any exposure does increase your risk. So I would say there's really little downside to getting the vaccine versus the huge potential of health protection effects if you get the vaccine.
Thank you. Any final words or thoughts, Dr. An?
No, I think I just want to impart that I just think that this, again, is such a preventable cancer, unlike a lot of the cancers out there. So we really do need to increase awareness. And I think just talking about it, making people aware of what causes cervical cancer is a really vital step in this situation. And of course, the increasing vaccination, as we talked about with the younger folks.